Good afternoon. We switch now to the randomized controlled trials. The first one was performed in 1948 by Austin Bradford Hill, a very famous epidemiologist. It was about streptomycin for tuberculosis. Meanwhile, it got the gold standard to investigate the effect of an intervention. And once more, the definition randomized means that each patient has equal chance of being allocated to a treatment group, and controlled means that there's a new intervention compared to standard treatment, or if there's no standard treatment, to placebo. I would like to discuss the control group with you: randomization, blinding, variations in trial design, and study reporting. The control group must be comparable to the intervention group in all relevant aspects except for the treatment of interest. Comparable means being similar on average for age, gender distribution, etc. Otherwise, we have a biased comparison. And the big advantages: we can, by using a control group, allow to draw conclusions about the causal relationship between treatment and outcomes. So that's the only way to really show that there's a causal relationship doing a randomized controlled trial. And the new interventions compared to standard treatment, when the treatment is already in routine use, or placebo when there's no standard treatment, we are not sure whether the new treatment is better than no treatment. And let's look at two examples, which is a little bit difficult to decide. First, equipoise. That's the specific term, which means that there's uncertainty about the benefit of one treatment compared to the other treatment. It's the only way you're allowed to randomize a patient. For example, you cannot randomize a patient to a harmful treatment. And there are sometimes difficult decisions to make about the standard treatment. For example, the Harvard study was about blood pressure lowering in patients above 80 years of age. And to me, the surprising decision, it was in the year 2008, was a comparison to placebo, but actually we didn't have any data at that time point that blood pressure lowering is beneficial in patients above 80 years of age. The study then finally showed that there is an advantage, so now we know, but at this time point it was correct to compare to placebo. Another one is the reverse AD study. It's about antagonization of dabigatran with a specific antibody in emergency situations. And there was also a lot of discussion what to do in patients who are critically ill and who to compare to, or what to compare to. And finally, the decision was that there was no control group because they said we cannot give nothing to patients in a critically ill situation. I'm not so sure. I think we would have benefited more if we got a control group, for example, with a coagulation factor concentrate. But the final decision was no control group. So sometimes it's difficult, very often it's clear what is the standard of care, but sometimes there are a lot of discussions. Let's go to randomization. Randomization means that there's a random allocation of participants to a treatment arm. It's like tossing a coin. Usually now it's done by computerized random number generator, and each participant has a known chance of being allocated to a treatment group. Usually it's 50%, but it can be also like 66% or something else. The important thing is that each patient has the same chance of being allocated to one of the groups. So if it's 66%, each patient needs to have the same, each participant has to need the same chance. And if you take equal group sizes, so 50-50, it maximizes the statistical power. And neither the investigator nor the participant, of course, can influence or should influence or predict the allocation. So a randomization also needs to be ensured that this works and that there's no chance of circumventing the randomization. And the advantages of randomization is that correct randomization ensures comparability of treatment groups. So we do not have any allocation bias or no selection bias, and groups will be similar in all aspects except for the treatment. And it controls for known and for unknown confounder. That's the big advantage. So if you have an observational trial, we can adjust for known confounders, but in this case, automatically we have also control for unknown confounders. For large studies, we usually use simple randomization, and so each patient is randomized, each person, but simple randomization may result in relevant imbalances in small studies with regard to baseline characteristics, with regard to the number of participants assigned to treatment. So there are other methods of randomization, specific methods. This is block randomization, ensures that there's an equal distribution within a block of patients. So there's a balanced distribution of treatment within the block. And there could also be stratified randomization if I want to be sure that there's an equal distribution of relevant patient subgroups. So here we see block randomization with a block size of 4. And after each block, we know that there's a balanced treatment allocation, which is important for small studies. So actually the randomization occurs for the blocks, so they choose one of the 6 blocks and then the next block. But after each block, we know that there's a balanced treatment allocation. And stratified randomization occurs separately in relevant strata, for example in each strata, and stratified randomization prevents imbalance in these relevant subgroups. And it's also possible and often done to do block randomization in the strata, because the strata is smaller, to be sure that there's no imbalance within one of the strata. And here we see an example from the BEST trial, which compared PCI versus CABG. And they said eligible patients were randomly assigned in a 1-to-1 ratio with the use of an interactive web response system to undergo PCI or CABG. And the randomization was computer generated and was performed in random block size of 6 and 8 with stratification according to the participating center. So they wanted to make sure that in each center they have a balanced allocation, because maybe in one center PCI is better and the other one CABG is better. So we want really to be sure that in each center there's the same amount of patients going to PCI or to CABG. Let's go to blinding. Blinding means masking the identity of the treatment. There are different ways of blinding. Single blinded means usually only the patient is blinded. That's for example, usually used for surgical interventions. Double blinded is the usual thing to do when you use cardiovascular pharmacotherapy. So neither the investigator nor the participant are aware of the allocated treatment. And triple blinded means that additionally also endpoint evaluation committee is blinded. How can we blind? We can use a placebo. This can be a dummy remedy. This is a pill with same size, same color, and even a double dummy in case of comparison of 2 interventions with different aspects. Each patient receives the true intervention and an indistinguishable dummy for the other treatment. And for intervention, we can use sham operation, and I think this is getting even more important with anesthesia and an incision. However, this is ethically difficult and you have really to justify why you do this with a patient, but it's important for the results. The advantage of blinding is you avoid the placebo effect, so response to medical intervention, which results from the intervention itself, not from the specific mechanism of action of the intervention. And this is usually a huge effect, so we have to be very careful about the placebo effect. And masking of the participant avoids the reporting bias, as I discussed in the morning. So based on the beliefs about the treatment, the participant may unconsciously usually report events differently. And masking of the researcher avoids observational bias. So based on the beliefs about the treatment, the researcher may perceive events differently. And another thing, by blinding, we avoid compensatory treatment if one of the treatment arms is perceived to be weaker. So for example, if we think the new anticoagulant is weaker, we may give additional aspirin or something. So this compensatory treatment is avoided if also the researcher or the patient does not know what treatment he gets. Here's an example again. This is the Simplicity Hypertension 3 studies. And we had prior unblinded studies that have suggested that catheter-based renal artery denervation reduces blood pressure in patients with resistant hypertension. And the Simplicity Hypertension 3 study was a prospective, single-blind. Of course, it was an intervention, so the surgeon, of course, or the interventionalist knew what he was doing, I hope so. but the patient shouldn't know. It was randomized and sham controlled, so that's the important thing, that was the new thing. And patients with severe resistant hypertension were randomly assigned a 2-to-1 ratio. So to make this ethically more correct, at least 2/3 of patients got the real intervention, and only 1/3 got a sham procedure. And here we see the surprising results. Actually, if you look at the p-value of 0.98, we had, this way. We had a similar reduction of the blood pressure in both groups. So actually we had a huge placebo effect also in the sham group, with an average reduction by 4.8 millimeter mercury in the control group and 6.8 millimeter mercury in the intervention group, but this was not significantly different, the reduction. So actually what they have seen in the prior studies was mainly a placebo effect, and by really comparing it to a sham procedure, there was no effect left for the intervention itself. A lot of discussion why this was the case, if it didn't work technically, and there are now more studies coming about the topic, so we do not know. And this study is also another example that also an objective outcome measurement is important, because they use 24-hour blood pressure measurement and not only one office measurement of blood pressure. The probe design is a design which we'll see more and more often recently. It means prospective, randomized, but open label, blinded endpoint evaluation. So actually only the endpoint evaluation is blinded, but the medication is giving open label. And it's used when double blinding is very difficult or too complex, for example, for laboratory guided treatment. So if you need to adjust your treatment by laboratory measurements, if you have characteristic side effects, if everyone gets a red skin when taking the medication, it doesn't make too much sense to blind, of course, because then everyone knows what therapy he gets or she gets, and for device studies. And a probe design has some advantages. It may avoid a very or too complex study procedure, which may increase the likelihood of selecting particularly compliant patients. Study discontinuation of participants may also be avoided. So because this is very difficult to sham or double dummy study with laboratory guided measurements, where you need sham values then for the laboratory to decide it, sometimes it's better to do it in probe design. And the example for anticoagulation was the Relight trial. And the rationale was that the laboratory-guided treatment of vitamin K antagonist, including sham INR measurements, requires a very complex blinding. And the blinded study design may have led to frequent and uncontrolled unblinding, because by just taking a routine laboratory measurement, they knew what therapy the patient was on. And to minimize potential investigator bias in the assessment of events, several safeguards have been included. For example, outcomes were objective. Outcomes events were adjudicated by a blinded adjudication committee, and there were also 2 doses of dabigatran which were blinded. There were a lot of discussion about this topic, because then the later studies showed that it's possible to do also double dummy design in this case, and also FDA had some concerns about this probe design in this case, but it was the first study, and I think they had a good rationale to use a probe design. However, the other ones later on proved that it's also possible to do it the other way. But I think they're not so far away, because in the other studies we have the problem with frequent uncontrolled unblinding, of course. So the advantages of a probe design is more economic, it's less complex and therefore more similar to clinical routine, and there's a lower dropout rate, and it's not so difficult for the patient. And the disadvantages, with a differential probability of reporting events or reporting bias, and a blinded endpoint committee can only evaluate endpoints which have been reported. So if the endpoint committee does not know about the endpoint, of course they cannot adjudicate anything. Let's move to variations in trial design. What you usually have is a parallel group, so the group A gets the green treatment and the group B gets the red treatment. You can also use a crossover design, which means that the group A first gets the red and then the green treatment, and the group B gets the green treatment and then the red treatment. Usually you need a washout period, so you need some time to wait until the first treatment does not work anymore, and then you can start with the second treatment. The advantages are, for the crossover design, you have a smaller sample size as each subject is his own control, so you have no between subject variability. And the disadvantages, it does not work for acute treatment, so acute PCI you can do only once and not the second time, of course, for example. It's only for temporary treatments. You always have to think, is the washout period reliable, or you have a leftover effect from the first treatment. And patients are completely lost if dropout occurs before second treatment period. So if the patient go through the first cycle of therapy but not the second, then still the patient is completely lost. And here we have example, the BAFI-2 study, very economic study, a British study with 314 patients with resistant hypertension. And as you see, one of the disadvantages, only 73% completed all therapy cycles, so you have a huge dropout rate. And patients had to go through 4 cycles, doxazosine, placebo, bisoprolol, and spironolactone. And they had a 12 weeks treatment period for each. And the dose titration, there was a dose titration after 6 weeks, but there was no washout period because they measured the blood pressure at the end of the 12 weeks, so they were assuming that there was no leftover effect after 12 treatment of the previous treatment. And it worked very well. The results were fine, and they really showed the difference. Of course, only for a surrogate endpoint of blood pressure lowering, not clinical endpoints. Another variation is the factorial design. It allows testing more than one hypothesis in one study, so it increases the efficiency of research. Usually you have a 2x2 factorial design. This looks like here. So you have randomization to 4 groups. In the 4 groups you have all combination of treatment A and B. So one group with treatment B, one group with no treatment, one group with both treatments, and one group with treatment A only. Here we have an example, that's an infuse MI study, and here they tested on one side an aspiration catheter, the export catheter, and on the other side the infusion of Apixaban, which is a GP2P3A inhibitor. What is very important, that you need to check whether you have significant interactions between the two treatments, because it may be that the GP2B3A inhibitor only works if you have also an aspiration catheter the other way. And they checked, and there were no significant interactions between the two treatments. And a very recent example is the AUGUSTUS trial, and I think this is a very good example because we already have studies on this topic. It's about triple therapy, so patients undergoing PCI who need also anticoagulation. And we have the Pioneer study. We will get the redual PCI study, and both mixed up the 2 questions. And the 2 questions is whether the NOAC is better than VKA in this situation. And the second question is if you can skip aspirin and only use placebo. And the AUGUSTUS study makes this in a very good way because they really have a 2x2 factorial design and ask first the question if Apixaban is better than VKA, and the second question if aspirin is better, if you should skip aspirin, and if the placebo is as good as aspirin or even better. So they really separated the 2 questions, so we will get 2 answers from the study. The advantages of a factorial design: you need a smaller sample size than 2 separate trials. It can assess interaction, so the modification of the effect of one treatment by the other treatment, that's very important. And the disadvantages, there's added complexity within the one study, and the chance of adverse effects, of course, increases if you take 2 study drugs. So finally, let's look at study reporting. We already discussed this topic in the morning. There are standards for reporting of trials, the CONSORT statement for interventional trials and STROBE statement for observational trials. And this gives the gold standard how to report your clinical study. And very well known is the study flow, which is now in every paper and where it's really required to show what happens with your patient. So you really need to clearly show when you have what happened with the patient you screened, how many patients then finally were randomized, and what happened with patients after randomization. And here you see this checklist. It's not only this flowchart, but there are many more points which we discussed now, right? Like the trial design, like about the participant and the criteria for inclusion, about the intervention outcome, about sample size, about randomization. So there are many more points which you should need to report according to the CONSORT statement. And here many more also about reporting the results and also about reporting how to discuss the results. So let me finish. The advantages of randomized controlled trials is randomization, which means it avoids selection bias, it controls for known and unknown confounders, double blinding avoids reporting bias and observation bias, and the analysis of randomized controlled trials gives strong evidence of a causal relationship and multiple outcomes can be examined. There are also disadvantages. The randomized controlled trials are expensive and require a large study team, data restricted for several years, and external validity may be limited by volunteer bias, so strong effect in health-conscious participants, restrictions to geographical areas, complex study examinations, selection of composite endpoints not used for or not relevant for clinical practice, or incomplete reporting of adverse events. And you always have to ask before, is it ethically to randomize patient to one of two treatments? Thank you for your attention.